Good morning, everyone. Great to be at the CGC and report about our experience with running a large cancer panel in patients with solid tumors at Mayo Clinic. So all of us recognize that the value of tumor molecular profiling in the clinic is being increasingly recognized. In fact, in the time period between 2000 and 2018, the frequency of clinical trials designed to specifically target a molecular target has almost quadrupled from 15 to 55%. And not only the FDA approval of drugs that target specific molecular targets in a specific tumor type has increased, but also approval of FDA for drugs that are target molecular targets regardless of the tumor type is also increasing, with such approval of four targets within the last 4 or 5 years. One such target is tumor mutation burden, a target that requires the sequencing of at least 1 megabase of genomic space for an accurate assessment. Yet, a study that was performed and looked at data from 2017 to 2019 in patients with metastatic lung cancer found that only 4.3% of those patients underwent NGS-wide genomic testing. Probably this was driven by lack of coverage for such wide testing, and this study that was performed in 2020, they found that 80% of submissions were denied for a large cancer testing of 467 genes. And the remaining 20% were only partially reimbursed. And when always asked why the submission was denied, the typical response was, this testing is experimental. We listened yesterday about the data coming from Fred Hutchinson Cancer Center. They showed great numbers, and if you noticed, the improvement of reimbursement really started to pick up from 2019, and it would be interesting to see the experience of other institutions, including our own at Mayo Clinic. So the goal of this study was really to determine the clinical utility of a large cancer panel using the TSO500 kit in patients with solid tumor. Our patient cohort constituted of 2,666 patients who underwent genomic testing using the Mayo Clinic complete solid tumor panel that uses TSO500 kit. This is a testing that we have validated at Mayo Clinic and launched in 2020. We included in this target or region of interest 514 genes for the detection of SNVs and insertion deletions, 59 genes for amplification detection, and 55 genes for fusion detection. We also determined the status of TMB and MSI. With regards to variant classification, we followed the professional guidelines by ASCO-CAP and AMP as published by Lee et al. In 2017, and we used QIAGEN Clinical Insights software version number 2 to aid with the classification, but all variant classification was verified by genetic counselor and lab director. So here's the distribution of age and sex of patients included in our cohort. As you see, for the most tumor types, the age range between 40 and 80 years old, but for some tumor types, for some region tumor types like renal, sarcoma, and neuro cases, we see more pediatric populations. In order to define the clinical utility, we looked at the data in different ways, and then we settled on this schematic for how we define clinical utility in this cohort. We separated the cohort into two arms, therapeutic and diagnostic, prognostic, or indirect therapeutic implication. For the arm on the left, we looked first at the patients whose tumor is TMB high, and in those patients also we looked at the presence of any variants for which there is FDA-approved drug in other tumor types. Those patients who have, whose tumor is TMB low, we looked at the frequency of variants for which there is FDA-approved drug in tumor type. And the second arm on to the right, this included patients that who did not have any variants for which there is FDA-approved drug, whether in tumor type or in other tumor type. However, they included variants we classified as type 1A or type 1B, and those variants included either diagnostic, prognostic, or indirect therapeutic implications for the patients. Here's the frequency of the distribution of tumor types in our cohort by tumor type. As you see, the lion portion went to lung cancer, which contributed with 38% to our cohort. The second most largest type of tumor was a tumor of unknown primary, contributing with 17%. And the third one was other, where we included all tumor types with frequency less than 20 cases per tumor type. Now let's talk about the patients with TMB high. The frequency of TMB high, defined as 10 mutations or more per megabase in our cohort, was 27.1%. And the frequency of patients with microsatellite instability was 1.5%. And as you expect, all those patients with microsatellite instability were also TMB high. Staying within those patients with TMB high, this is the breakdown of frequency of TMB high by tumor type. As you see, bladder cancer and urothelial cancer contributed, like the frequency of TMB high was 49%, followed by lung cancer with 39%, and then with esophageal and tumor of unknown primary with 30% each. Within this cohort also, we looked at the frequency of variants for which there is FDA-approved drug in other tumor type other than TMB high. And again, as you see, the highest frequency came in bladder cancer with 38%, followed by brain at 32%, and then with esophageal cancer at 25%. And the overall frequency of such variants was 6.8%. Now, switching gears to the cohort with patients with TMB low, we looked at the frequency of variants for which there is FDA-approved drug in tumor type. And as you see here, lung came out on the top with 53%, followed by breast at 40%, and then thyroid at 35%, with an overall frequency of 18.8%. Now, this remaining category is a cohort of patients where there is no variants for which there's an FDA-approved drug. However, they had a variant that we classified as type 1A or type 1B, either because of indirect therapeutic implications, like KRAS, for example, G12, G13, other than G12C, in patients with colorectal or lung cancer. And this is the breakdown by type of variants, and as you see, KRAS gene came on the top of those genes at 56%. The overall frequency of this, such variants was 13.6% in the entire cohort. Now, it's tempting to see how these different types of variants that we found to have clinical utility in this cohort of patients, how they relate to each other in terms of frequency. And as you see, compiling all the SNVs together, they contributed with 48% of the entire clinically relevant variants, followed by TMB high alone, which contributed by 41%, then gene fusions at 5%, amplifications at 4%, and finally microsatellite instability was 2%. This is a caption of a summary of all findings. The frequency of TMB high was 27.1%. The frequency of variants with FDA-approved drug in those patients with TMB low was 18.8%, and then the frequency of variants with approval or FDA approval in other tumor types was 6.8%, and the combined frequency of type 1A, type 1B variants was 15.2%, and the overall frequency of variants with clinical utility was 67.9%. In conclusion, 27.1% of patients in our cohort were found to be TMB high, and TMB high was the most frequent single biomarker with an FDA-approved drug in this cohort. MCSTP testing in our cohort identified a therapeutic target with FDA approval in tumor type other than TMB high or in other tumor type in 25.6% of patients with solid tumor, and the frequency of variants with diagnostic or indirect therapeutic relevance was 15.2%, and the overall estimate of clinical utility of MCSTP testing in our cohort was 67.9%. Finally, I'd like to acknowledge the contribution of our team. Lisa is the first author on this paper. She couldn't, unfortunately, she couldn't be here. Adam is our IT guy. Claire and Amber are genetic counselors. Beth is a variant scientist, and Dr. Holling is our section head in oncology. Thank you for your attention.